Okay, so we have Stephanie Oliver doing her 12-lead ECG assessment. Student number is 15917495. You've got a minute to take notes on your steps if you want to.
Okay. Yeah. A minute. We'll start. Okay. Okay.
Okay, I'm going to give you one of the ECGs and if you could read out which number it is.
Number 3.
Right, I'm going to give you a brief history of it and you can ask again if you need to know more about it.
Okay.
So you have a 23-year-old female has described her heart as racing with shortness of breath. She's under investigation for recent episodes of the same thing, pending a Holter monitor. She says it's not currently racing anymore and there is no chest pain.
Okay.
So we're going to start a timer and...
Okay. Timer starting.
Okay.
Go. Okay, so I'll start with general impressions. Got some very tall R waves in the precordial leads. Got a little bit of elevation looking type V1. And I've got delta waves in 1 and 2. It looks somewhat irregular rhythm. Nothing shouting out, screaming terrible at me. I'll do a few tech errors. The paper speed should be 25 mil per second, which we don't have. We don't have a frequency response, which should be 0.05 to 150 hertz. I've got half a calibration spike, which should be 0.20 seconds wide and 10 mil high. AVR is negative, so it tells me that the limb leads should be in the correct position. There's not much artifacts. There is a QRS in every lead, and I have no date, no name, no how the patient was feeling or interventions. And my R wave progression is early in V1. I'll go ahead and check the rates and see if it is regular, which it is. So then I can use the 1500 method. Count the squares in between two R waves, which is 5, 10, 15, 20, 21. So 1500 divided by 20. 1500 divided by 21 is 71 beats per minute. And I'm looking for my P waves now. I've got P waves, one for every QRS. Normal complex, so I've got normal sinus rhythm. The P waves should be upright, symmetrical, which they are across the lead, yes. And I've got a short PR interval, should be 0.12 to 0.20 seconds, and this looks like it's much less than that, sort of I'd say 0.08 seconds. We have short PR. And I've got a delta wave, which leads me to Wolf, Parkinson, White. So PQ, I'm looking for Q waves. Could be Q wave in lead 3. But I'm going to go with that's usually Wolf, Parkinson, White. Looking Q waves in the precordials. No, pathological Q waves need to be greater than 0.03 seconds wide or a third height of the R wave. QT interval, since it's normal, I can look halfway between the two R's for the T wave, and it's not more than halfway, so do not have a prolonged QT interval. QRS, it is prolonged, which fits with Wolf Parkinson. It looks like 0.16 seconds. Normal QRS should be less than 0.12 seconds, a normal 0.06 to 0.11 seconds wide. ST changes. We do have a little bit of depression, which needs to be more than 1 mil and 2, but it's not contiguous anywhere. Possibly a little bit in 1, but not enough to meet that criteria. We've got some elevation in V1, V2. If it's a female, age 23, it needs to be more than 1.15 mil high. But these changes usually go along with Wolff-Parkinson White as it's a STEMI mimic. And T waves should be asymmetrical. And upright, we have some negative in the lateral leads, V5 and V6, V4, and tall, peaky, and higher than 2/3 the height of the R wave in V1 and V2. So we have some ST wave changes. Morphology would be the QRS complex. So the intrinsicoid deflection is a little bit prolonged, but it's pseudo as that's coming from the delta wave. We don't have any bundle branch block criteria met in V1. There's no bundle branch blocks there. Hypertrophy. So I'm looking for the Sepal-Lyon criteria. And V1, V5, which looks like it could be, but also it fits in lead 1 is greater than 12 mil. So we do have left ventricular hypertrophy. And then we'll go for axis. So using the thumb methods in 1 and AVF. AVF is negative, so it looks like it could be left axis deviation, but I'll just quickly graph it out to make sure. We've got 5, 10, 15, looks like 20 positive across to the right, and AVF, we've got Norway, 1 minus 5, so -4, so we go up 4. Graph that out, I'd say that's right on about -15 degrees. So between 0 and -15, which is still normal axis, we've got normal axis deviation. And then do we have some STEMI criteria? Well, she doesn't have any chest pain at the moment. She does have a little bit of elevation in the precordial leads, V1 and V2. So I guess you could look at having a posterior ECG to look and see if there's any changes, but those are symptoms seen with Wolff-Parkinson White. So interpretation would be normal sinus rhythm with Wolff-Parkinson White and left ventricular hypertrophy. And I guess you can always rule in a mimic, but you can't rule out a STEMI. So check on those, have her see a doctor, and have a look at the posterior ECG.
Okay. By posterior ECG, you see no ST depression or elevation.
Okay. So then I would just stick with the Wolff-Parkinson White.
Okay. That's your interpretation.
That is.
Great. So there's 2 questions to go along with this. What is the accessory pathway known as in Wolff-Parkinson White, and why does it show a widened QRS delta wave?
It's the bundle of Kent is the accessory pathway, and what happens is it bypasses the AV node, so you don't get that block, and so the delta wave comes about from the action potential going straight into the ventricles in sort of an early start for the QRS complex before they join back together for the full complex.
Okay, and the second question, what are the other short PR interval syndromes and how do they differ electrically to Wolff-Parkinson White on an ECG?
Those 2 would be LGL and Mahim fibers, and they differ. They also skip the AV block, so they have the short PRI, but then they join back onto the normal conduction pathway, so they don't produce the delta wave. So there's not the widened QRS like you see with Parkinson White.
Okay.
The end.
So that's the end of that one. Stop recording.
Whoa.